Alright, what do you want to look? Number one is to list some reasons why you do a vertebral exam, and we go back to that. It could be because of any of the vertebral basilar symptoms, or that the vertebral is what type of flow?
Retrograde.
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 Yes.
Stop.
Or it could be any of those flows that we learned about. Tarsus parvis, all those things, okay? And then, why would you do subclavian? Because they have a subclavian groove, which is an abnormal sound. They're different. The blood pressure is more than 20. Subclavians are supposed to be low resistance, okay? And they're supposed to be antegrade. So if you find a high resistance or retrograde, then that would be abnormal also. All right, number 3, explain how to find vertebrals. Placing the CCA out long, angle lateral to the bed, look for the vertebral processes of the spine, shadow down, and the vertebral arteries will be in the middle, okay? All right, the next one, what is the most common vertebral pathology? Subclavian still. It occurs more on the left side. And if you find retrograde in the right vertebral, what should you do? You should go to the subclavian. Subclavian's retrograde, so we're going to go where? We're going to go, well, subclavian's retrograde, so we're going to skip the nominate and go where? To the CCA, remember? You got to take your CCA flow. Then if the CCA flow is abnormal, it's an anominate issue. If the CCA flow is normal, there's nothing wrong with the anominate, and the disease is in the proximal subclavian.
So would you say that one more time?
Yes. If you find retrograde in the vertebral on the right side, you're supposed to look at the subclavian.
Okay.
Subclavian's retrograde, so you're thinking the anominate is still in from the subclavian, that's why it's retrograde. But you must first Doppler the CCA. If the CCA is low amplitude and rounded, remember, then it's anominate obstruction. If the CCA flow is normal, there's nothing wrong with the anominate. It's the proximal subclavian that has the occlusion. So the distal and mid subclavian is retrograde to supply the proximal. If the anominate's okay. Let's see, number 7 is the right. Number 8 is tardius parvis. 9 is progressive early systolic. And 10 is retrograde. And today's Jamie and Rebecca's day. That up. Oh, they're up here. They're all up here.
So we don't have it in class?
No, in class, because I was too lazy. Thank you. Normally I do. I just didn't today. Case studies are due right now. Yes. Huh? No, it's today. Okay. I had a whole bunch of venous studies of the leg saved, and Miss Krim got excited and erased everything. So I don't know if I have any lower extremity studies. That's what I'm looking for real quick, so I can show y'all. Yeah. But it wasn't too good. Let's see. Oh, thank you. I should have done that. Okay, this one will be okay once we get started. Alright, so chapter 5 is talking about venous anatomy and how blood flows through the vein. Okay? It's pretty long, lengthy chapter, so I'm hoping that we get through it today. But just in your mind, and probably a lot of y'all done case studies on it, what's the most common reason to do a venous study of the leg? DVT, a blood clot. That is the most common reason to look at the leg to do a venous study. And it's called a DVT, which is deep venous thrombosis, or a blood clot. I think we've mentioned that already before. Okay? I want to go ahead and tell you just a few more reasons for why you may be called in to look at the leg for a venous study. If the patient needs to have a bypass graft in their leg, that means they've got a blockage in their artery, okay? So they most commonly are going to use a vein to make a bypass around that artery. So a DVT, a bypass graft. Why veins? Because they use a vein to bypass the artery, and we're going to talk about what vein they can use and why they can use it. A reflux, we're going to mention that today. Has anyone ever heard of reflux in the legs or valve incompetence? Anything like that? All right, that's another reason. And those are your most common. If I think of another one, I'll let you know. Okay? But Chapter 5 is first going to go over the anatomy. The very first paragraph, you have different types of veins in your leg. You have what's called the deep vein, right? And then you have what's called the superficial veins, and we're going to talk about all those. You also have what's called the dermal veins. Anybody got any spider veins or varicose veins? This is where those veins come from, the dermal veins, okay? And then you have perforating veins. We'll mention those. And then muscle tributaries, that just means that where the blood kind of sits in your muscles, that's what a muscle tributary is, okay? And we're going to talk about how blood gets in a muscle and how it gets out of a muscle and all that stuff in a moment. All right? Distal always means away from the heart, and proximal always means close to the heart. And it mentions that because if you don't know, arteries carry blood out of your heart down, then they cross over to the venous system, and the veins got to bring the blood back up to the heart, okay? So even though veins are backwards and they're coming from down, down to up, distal's still down here, proximal's still up here. It doesn't change, okay? Same difference. We're going to talk about the deep veins first. Deep veins, they have arteries that have exactly the same name, all right? So deep veins have arteries with exactly the same name, and we'll mention all those, except for the IVC. We all know what's opposite of IVC, aorta, okay? And then deep veins carry 85% of your blood volume, so they carry the majority of blood in your legs. The deep veins do. If you have a blood clot, you will only get blood thinners for deep veins, okay? So superficial veins, dermal veins, perforating veins, you're not going to get a blood thinner from. You only get a blood thinner if you have a blood clot in a deep system. That's important for y'all to know. Another thing that you may not know is how many of y'all think that a blood thinner gets rid of a blood clot? It's okay if you think it does, but it doesn't. Blood thinners do not get rid of blood clots. They help to prevent you from getting another one. So the blood clot that you have ain't going nowhere. All right? You will hope that your body will thin out that blood, because what a blood clot is blood that sticks together. All right? So you hope that your body will be able to thin it on its own and move it through the system, make it so small that even if it does throw and become embolism, it doesn't get lodged in your heart or your lungs or something like that. So, but a blood thinner will not get rid of the blood clot that you have. So a lot of people that have a blood clot will have it forever. Okay? So we're going to talk about the deep system first. Now, this book does work from top to bottom. All right? Even though veins start at the bottom of your foot and come up, we're going to talk about how they work from top to bottom. So IVC is your very first deep vein. Everybody here knows what an IVC is, right? All right. The IVC, well, we're going to talk about it coming down at the level of the belly button. It turns into the common iliac vein. Have y'all learned about any of this stuff so far?
Yeah,
fabulous. All right. So you have learned about the common iliac vein, splits the level of the belly button. Then the common iliac will turn into the internal iliac and the external iliac. And you can see it in the book. You can see it on the handout I gave you. So the common iliac vein bifurcates at the level of the belly button, turns into the internal iliac vein, then the external iliac vein. The internal iliac vein is a very short branch, and it actually is going to drain blood from your pelvic region and your buttocks, okay? So the internal iliac is this very short branch that drains, because veins drain, so it drains blood from your pelvic and your butt. Another word for internal iliac is hypogastric. That might have been a word y'all heard before, the hypogastric. And does anyone know, y'all are scanning it right now, do you know where you can see the internal iliac at? And the ovary, yeah, and then next. So y'all been looking at them, y'all just might not know that's what you're looking at. So the internal iliac vein and artery blade. If you need to find ovary, then you can't turn on color. Ovaries lie on top of that artery vein. So there's a way for y'all to start finding them if you can't. So the internal iliac is a short branch you can see on this diagram, then it stops. But the external iliac vein is the one that's going to continue down the leg and turn into the common femoral vein. So common iliac does divide into internal and external, but external is the one that will continue down the leg to turn into the common femoral vein. After that, you go through what's called the inguinal canal, inguinal ligament right here. That's where the external turns into the common femoral, right here in the groin. I know I say it wrong, but right there, okay? So the external turns into the common femoral after it passes underneath the inguinal ligament. So right here in the groin. Next quarter, we're going to do carotid all this quarter. So we'll start next. Alright, so once you get to the common femoral vein, it tells you the next thing, it splits into what's called the femoral vein, which was once known as the superficial femoral vein. I will tell you, since I'm a little old school, I still call it the superficial femoral vein. On a test, it probably will say SFV, superficial femoral vein. Okay, I won't just call it a femoral vein. So the common femoral vein splits into the superficial femoral vein, and then the next one is the deep femoral vein, which was once called the profunda. You may see that either way, so know two different words for deep femoral vein. Could also be called profunda. Okay, then once you, the deep femoral vein kind of acts like the internal iliac. It's a very short branch. The purpose of the deep femoral vein, just like the deep femoral artery, is to act like a collateral. Collaterals form when your body has an occlusion. It's your body's own way of making a bypass graft. Okay, so the deep femoral, or the profunda, their purpose is to act like a collateral in the event of an occlusion. That means that they'll make their own little bypass in your body to get blood around the occlusion, and it'll last for a little while, but eventually you're going to have like a man-made bypass put in. But it's our body's own way of being able to go around that blockage. Collateral, C-O-L-L-A-T-E-R-A-L, thanks, right? But anyhow, and that's what a collateral is. It's your body's own bypass graft. Okay? Now, once you get to the common femoral, it splits into the superficial femoral and the deep femoral. Then what happens is the superficial femoral, it runs the entire length of your thigh. Okay? So it goes from here to the top of your knee, the entire length. And it's divided up into props, mid, and distal. So you have a proximal SFV, mid, and distal. Okay? So it runs the whole length of your thigh. Once you get to the distal SFV, it wraps behind your knee and turns into the popliteal vein. Okay? So the distal SFV goes behind the knee and turns to the popliteal vein. Now we're going to stop right there for a second because we just talked about how they go down the leg, but you need to know how they go up the leg. Okay, because they're veins. So, anytime I give you a test, this is the way I want you to know it. If I said, what does the popliteal vein turn into? What do you think your answer would be? But which one? The distal SFV. Okay? So the popliteal vein turns into the distal SFB. What does the distal SFB turn into? Mid. Mid turns into proximal SFB. Alright, once you get to the proximal SFB, it does turn into the common femoral vein, but what does it have to join with first before forming the common femoral vein? The deep femoral vein, okay? So once you get to the proximal SFB, it'll join in with the deep femoral vein, then those two will combine and form the common femoral vein. Okay? Everyone got that? If you don't, tell me. Aaliyah, got it? Alright, she hates this chapter. Okay? Once you get to the common femoral vein, what does it turn into? What is the common? The external iliac vein. Very good. Okay? Before the external iliac vein can turn into the common iliac vein, what does it have to join with? The internal. So the external and the internal join to form common iliac. And what does the common iliac vein turn into? IVC. That's the way you have to know vein. Okay? Even though this book mentions them going down, you've got to know what they form coming up. Right? The popliteal vein turns into distal SFB. Distal turns into mid. Mid turns into proximal SFB joins with the deep femoral. They form common femoral vein. Common femoral vein turns into external. External and internal iliac join to make common iliac, and common iliac turns into IVC. Larry? Now look back there.
No, the GSV.
We're going to talk about that in a
Okay,
minute.
because I'm
Don't even worry about
Alright,
it. That's
no
a
problem.
superficial vein.
Okay.
We're not talking about that right now. But it doesn't stop when you get the pop, but I just wanted to be sure that we were okay
yeah, that's-
to the pop. Because you got to talk about the veins in the calf. Okay? So on the next page, this is where it's going to start mentioning the veins in the calf. The popliteal vein forms what's called the trifurcation. So you have a bifurcation, which is 2. Trifurcation means 3. So the popliteal vein branches into what's known as the trifurcation. And I don't see it right here in this book, so be sure you write it down, that the popliteal vein branches into what's known as the trifurcation. And you see those 3 bullets at the top of that page 98? The very first branch off of the popliteal vein is the anterior tibial vein. Okay? So the first branch off the popliteal vein is the anterior tibial vein.
So what you said before then?
The popliteal divides into what's called the trifurcation because it divides 3 times. And the first division, the first branch, is the anterior tibial vein. The anterior tibial vein drains exactly what it says, the anterior part of your leg. So to find it, you will scan on the lateral anterior, right beside, which one's your bigger bone? Tibia? I hate bones. But anyway, the bigger bone, the more lateral, you put your probe right beside it and angle out towards it laterally, and you're going to bring in anterior tibial. So it's anterior, but lateral on your leg. So it drains the anterior part of your leg, okay? Now, this is where people get confused. The second branch off the pop is called the tibio-peroneal trunk. This book doesn't mention it, okay? So the second branch off of your pop is called the tibio, T-I-B-I-O, and then peroneal, P-E-R-O-N-E-A-L, tibio-peroneal branch. The second branch off of the pop is called the tibio-peroneal trunk. Are they calling it something else? No, he just completely skips it in this one. I know. Yeah, he does. Now, if you look at the bottom of page 98 in the drawing 1, 2, and 3, you see where he's got the word tibio-peroneal trunk there. He just doesn't mention it at the top for some reason. Okay? So your first branch off your pop is anterior tibial. The second branch is the tibio-peroneal trunk. Right? Then the trunk will divide again, and this is where the third branch comes in. So don't let this confuse you. Even though it's the third branch, it divides into 2 more veins. Okay, so there's actually 4 different segments going on, but it only divides 3 times. All right, so the tibial-perineal trunk divides into what's called the posterior tibial and the perineal veins. So the tibial-perineal trunk will divide into the posterior tibial veins and the perineal veins.
So the legs are not branches, they just branch off the trunk.
They branch off the trunk, exactly. And that's why it's called trifurcation, because it really only branches 3 times. Anterior tibial, trunk, and then trunk will branch again, but it does branch into 2 veins. The posterior tibial and the perineal veins. You're very welcome. Now, to find the posterior tibial vein, you actually will put your probe medial to your ankle bone. Okay? So on the inside of your ankle bone, that's where you're going to find your posterior tibial. And then your perineals, you just put it in the medial calf, like the real thick part right here. That's where you're going to put it at. And like I said, when we get to scanning, we'll talk about that a lot more. All right, so what 2 veins form the trunk? Perineals. Good. All right. What, the trunk and what form the popliteal vein? Anterior tibial. All right, very good. So y'all got it. And then the anterior tibial vein turns into popliteal. Popliteal turns into distal and mid and cross, and you work your way on those. Okay? So are we good with the veins? Those are just your deep veins. We got several more to talk about, but those are just your deep veins. One thing to know is that once you get to the anterior tibial, posterior, and the perineal, they have 2 veins and 1 artery. Okay? So posterior tibial, anterior tibial, and perineal, you have 2 veins and 1 artery. All the rest of them is just 1 vein, 1 artery. Yes, so anterior, posterior, and perineals, you have 2 veins and 1 artery.
The rest is 2.
The rest has 1 vein, 1 artery. And it says it right there on top 98, beside anterior, posterior, it says paired. It means 2 veins, okay? So the rest of the popliteal just has artery and vein. Superficial, just artery and vein. But once you get past the popliteal, you've got 2 veins and 1 artery. And they're all, you got 2 perineal veins, 1 perineal artery. So they've got the same name still, okay? The deep system, arteries, and veins have the same name. Alright, so please stop me if you're not getting this part before we move on.
So how did you repeat those 2 veins?
Anterior, posterior, and perineals have 2 veins and 1 artery. Everything else is 1 vein, 1 artery. Right, then what can happen though, and it's very common in legs and arms, is you have what's called a bifid system. So you have 2 separate systems. Okay? For instance, in this little picture here, this is a picture of the SFA. So it should only have 1 vein, correct? But it has 2 veins. That's a bifid system. Okay? It's got more than the 1 normal vein. So bifid means 2 systems. And it says it's not uncommon. It's seen in 30% of people. So that's what bifid means. You can also have a trifid system. I've seen them up to 4 times. You know, so it can get tricky if they have more than the normal. But if they have 2 veins, both veins need to be looked at, just like if it was just normal 1 and 1. Okay? Everything still needs to be looked at. We'll come back to the bottom of page 98. Go on to page 99. Here it's just showing you again the posterior tibials, the perineals, and the anterior tibials. You can see in the color picture, see how we've got 2 veins and 1 artery. Okay? So again, we'll talk about, we're not worried about that right now because that's telling you where to go to scan. Just know that anterior tibial is on the lateral side of the leg. Posterior tibial is behind, is medial to your calf, your ankle, and then perineals are in your calf. And that's all I want you to know for now. They have 2 veins and 1 artery, okay? All right, at the bottom of page 99, you have what's called calf muscle veins, and this means that exactly what it said, it's draining the calf muscles, okay? The first one is the gastrocnemius, we always call them gastroc, okay? Gastrocs drain into the popliteal vein. So when you're scanning the popliteal vein, you ought to see these smaller veins draining into the popliteal, okay? And then the next one are the soleal veins. They drain to the posterior tibial and the perineal veins. So gastrocs drain to pop, soleals drain to posterior tibial and perineal. The most common place for a thrombus to start is the soleal. Right, so that will be a test question. The most common site for thrombus to start is in the soleal vein. Thrombus to start. You can turn over to page 100. The very first picture is showing the popliteal vein lengthened out and long, and you can see the gastroc draining into it. Okay? So there's just a little example of how you can see it. The second picture is transverse of the gastroc and the soleals. But then it says in this paragraph that soleal veins drain to the posterior tibial and the perineal. It's not routinely that we scan these, okay? Most of the time you're just going to do anterior, posterior, and perineal and be done. But if a patient comes in hurting in their calf, it's very important for us to scan these veins because they're the most common site for thrombus to start. And so that's what it said. However, if a patient complains of pain or tenderness in the calf, you should look for thrombus in the soleals or the gastroc because they lie within the muscle. If they do have thrombus in them, they can be a very considerable source of pain for the patient. Okay? So even though not routinely seen, as a tech, as a good tech, we won't take that extra step, especially if they're hurting in their calf, and look at them. Alright, now we are going to go into what's called the superficial system. It's much easier, you only have 2 veins. So, it's the much easier one. Now, a superficial veins do not have arteries with them. So they're by themselves. They only carry 15% of the blood volume. And if you have a blood clot in them, you don't get a blood thinner. Okay? The first one we're going to talk about is called the greater saphenous vein. It goes the entire length of your leg. It starts at the groin and goes all the way to your ankle. So it's the longest vein in your body, the greater saphenous vein. Longest vein in your body. You can see right the very first sentence on page 100, the greater saphenous vein courses medially and enters the deep system at the common femoral vein. I just said they go from the groin to the ankle, but how do veins do? Veins go from bottom to top. So the greater saphenous vein enters into the deep system at the groin. And what vein is the groin? Common femoral vein. So that's what you asked me about a minute ago. So the greater saphenous vein enters the deep system at the common femoral vein. That will definitely be a test question. The greater saphenous vein, longest vein in the body, but it enters the deep system at the common femoral vein. Alright, now I just said you don't get a blood thinner if you have a blood clot in the superficial system, unless, there's just always an unless. If you have a blood clot right as the greater saphenous vein is entering the common femoral vein, they're going to go ahead and give that patient a blood thinner. If it's so close to the deep system, they want to go ahead and give a blood thinner. Even though it's not going to dissolve it, maybe it will thin it out, make it smaller in case it does break loose, okay? So there always is an unless. You will get a blood thinner in the superficial vein if it is close to the deep system, right? So the greater saphenous vein runs the entire length of the leg. I find a blood clot in the calf greater saphenous vein, no blood thinner. Even if I find it in the mid-thigh, no blood thinner. But if I find it very close to the common femoral vein, chances are they're going to put them on a blood thinner, okay? Everyone got that? Okay. It says the greater saphenous vein lies in a facial envelope. It is sometimes called the Egyptian's eye or the Cleopatra's eye, and it's on page 101. You can tell that the big picture here, the greater saphenous vein, just kind of looks like it's an eyeball. Okay? That's where they get the name from. And you will see that on the test. You know, greater saphenous vein sits in the facial envelope called the what? Cleopatra's eye or Egyptian's eye. And there it is. It's all by itself. Okay, because it doesn't have an artery with it. But where does it enter the deep system at? Common femoral vein, and it's the what vein in the body? The longest vein in the body. Alright, the next one is on top of page 101. It's called the small saphenous vein, previously known as the lesser saphenous vein. So just to warn you, I still call it lesser saphenous because it's just such a thing I cannot break. But the lesser saphenous or short saphenous, it courses posteriorly in the calf and enters the deep system at the popliteal vein. So it just is in the back of the calf and it enters in the pop vein, okay, usually. Again, a patient's not going to get a blood thinner unless the DVT is at the junction of the popliteal vein. Okay, so again, if it's close to the deep system, they'll get a blood thinner. Okay.
It enters the deep system at the
Usually. Yes. It says that in approximately 20 to 30% of patients, the lesser saphenous enters above the popliteal vein, and it's called a Giacometti vein. So know that word. Okay. So if the lesser saphenous vein, it's normally supposed to enter the pop vein, but if it doesn't, let's say it enters the distal SSV, it's called a Giacometti vein. Okay. And it is a finding that you need to report on your tech sheet. It's not like it's dangerous to them, but if they ever needed to go in and do an ablation, which is where they burn those veins out, they would need to know that sort of thing, okay? So normally, lesser saph enters pop, but if it don't, it's called Giacometti vein. The next thing is the subdermic system, which is called the dermal system. And again, this is where spider veins will come from, okay? That's what it says, source of spider veins. Don't worry about the accessory saphenous vein. Don't need to go over that right now. Alright, so we went over our deep veins. Y'all probably talked about every deep vein in the leg. We talked about our superficial veins, okay? The next thing are perforating veins. They're super easy. Dermal, yeah. Alright, you're fine. If you have a deep system and you have a superficial system, they got to connect somehow. It's two separate systems. How do they connect? By perforating veins. Okay? So perforating veins, just like it says on the very first sentence, they connect the superficial and the deep system. Flow goes from superficial to deep. That's important to remember for the end of this class. Flow should go from superficial system to deep system. Because when it gets into the deep system, that's when it eventually gets to the IVC, and IVC carries blood where? To the heart, and then the whole process starts over again. It says perforating veins have valves in them that open and close and prevent blood from getting back into the superficial system. So flow should normally go to superficial system, valves open, let them into deep system, valves closed, so it can't get back into superficial system. Sometimes that breaks. I'll talk about that later.
Before you say it, what you said.
I don't know.
Right after the deep and superficial.
They have valves in them, flows from superficial to deep. You have valve or perforating veins all throughout your leg. This goes over just some of them, okay? So the lower calf is called the cocket. Another word that I'm afraid I may have put on your test that's common is called lintons. Lintons. So if you see the word lintons perforator, that means the ones in the lower calf. Okay, just another word for cocket. And then it goes over the ones in the thigh, Dodds and Hunterian. So, just some of them. There's plenty more, but that's all we're going to mention right now. And normally, you should not see perforating veins. Okay? Normal. If there is an issue or flow from the deep system is getting back into the superficial system, those valves dilate, and you can see them then. You can see perforating veins then. But normally, you should not see perforating veins. Okay? Page 102 goes over a little diagram of perforators. You can see the Dodds, Hunterian, Cockets. Okay? So, there's just some more pictures. And, good, we're already on to hemodynamics. That's awesome. How's the clock get out? Awesome.
Will you know anything on paper?
What was the question?
Do you need to know anything on top? You don't need to know anything on 102 except for that little graph. And you don't need to know that. It's just an example of where these perforators are. Alright, so, do we have deep veins? We know what they turn into, all that wonderful stuff. Superficial veins. We know where they enter the deep system. Okay? Perforating veins. We know what those are. Connect superficial to deep. Yes, flow should go superficial to deep. If my lesser saphenous vein enters my mid-SFV, what's it called? If my lesser saphenous vein enters my mid-SFV, what's that called? Giacomani, because where should the lesser saphenous vein enter? The popliteal. Where does the greater saphenous vein enter? Common femoral. Good. Very nice.
So we don't need to know the knee perforators, Sherman's, or...
I mean, I might throw that in on the test. That's why I'm saying just look at that little diagram of which perforators are what. Because I'd hate to put it on there and not have went over that little part. So just look at them. Because I have a little diagram of arrows and look at graphs. So that obviously means y'all need to look at them. Okay? Let me see. I think chapter 6, we're not done, but yeah, chapter 6 goes over more of the imaging of veins. But I just want to show you just like a few images of a venous study, so maybe you have a better idea. Well, the hemodynamic part of it is a little bit long to me. I'm going to put the lights off for a minute, and I want to pass that on. Oh, that's really dark. Shoot. I really can't even see that. Shoot, I can't see it. Let me just see someone else to see what they're doing. Okay, this one's not too bad. Can y'all point them out? Artery vein. I can't really point the greater saphenous vein on that. Hang on, I'm going to find one that's good. Yeah. Oh yeah, there we go. I knew I could trust her. All right. So this is a picture of transverse of the vein. All right. So if you have your common femoral vein, you got to have what? Common femoral artery. And what enters the deep system at the common femoral vein? The greater saphenous vein. So here it is entering the deep system. Now, some people, and hopefully I'll find one, some people have really big greater saphenous veins, a little bit easier to see, okay? So your artery and your vein, same name, there's greater saphenous. One thing that you do for a venous study, we're checking for blood clots, okay? So you actually will compress their veins. You just push down with the probe very gently, and you can see how now they've closed. All we have left is the artery, okay? So the common femoral vein's gone, and the greater saphenous vein's gone. We're only left with this right here, which is that artery. All right. So if you have a blood clot there, they're not going to compress. So that's just kind of an idea. We'll talk about a lot more next week of what you're looking at. Also, you can use color. They should fill in all the way. See the greater saphenous vein coming out over here? So they should fill up all the way with color. It's kind of like arteries. If they don't fill up, you're thinking plaque. If a vein doesn't fill up, you're thinking a blood clot. Okay? Now, the most dangerous thing that I see done, and she done it, so I'm going to have to beat her for that, but just like you have anechoic thrombus, or anechoic plaque, you have anechoic thrombus, okay? So a blood clot that's very new, we won't even see it on a grayscale image. It'll look just like this. It'll look perfect. Now, anechoic, or not anechoic, but acute thrombosis are the most dangerous kind because they have not had time to attach to a wall, so they're just floating around in there, okay? So an acute thrombus will be anechoic, can't see it on a normal image, but they are the most dangerous because they're just floating around. So, should you compress and push down on a possible acute thrombus? No, because if you do, chances are it'll break loose and throw to the IVC. Where does the IVC go? To the heart, okay? So the very first thing you're supposed to do is put color on it first. If color fills in, you know there's no thrombus there, so you're safe to push down. If that image right there, the color did not fill in those veins, I'm not pushing down because there's an acute thrombus there. So when y'all start scanning, and like I said, we'll talk about this a lot more next week and next quarter, let's put color on, even in here, just get in the habit of doing it. Let's put color on things before we go to compressing, because we hate to throw and kill somebody, okay? I think it was Miss Bandu was telling me a story, I don't know if it was her or someone, they done a study, pushed down, the patient died right there on the table while they were scanning them. Threw it right to their heart and killed them. So, you have to be really careful before pushing down the thrombus, all right? So it's very important to put color on before you do it. But that's just an example of what y'all will be doing.
That doesn't terrify me at all.
Here's a good picture of the anterior tibial. See, the two veins are blue and the artery's red. Okay? So that's what you'll be looking at. Let's see, I'm looking at that right now to confuse you. That's not very good. So anyhow, but he doesn't really have a good one of the. He's calling this a vein, artery, and vein, and that might be a vein, but I like a little more fill in. So anyhow, but that's what y'all will start doing. I don't have a picture of the electrostatic going into the popliteal vein. Okay. Transverse is your box straight up and down. But once you get to below the knee, anterior tibial angles to the right of the screen, so your box has an angle with it. And then posterior tibials and perineals, that angle is what makes them angle. That's the good thing about legs. There's no certain angle in long. It's kind of up to you, except for this one. This is the only one that has a certain angle. So a lot of people like doing legs a little better. A little more to some scanning wise, but anyhow. Okay, so that's just an example of what y'all just saw. Now, we're going to get into the hemodynamics part of it. How does blood get back to the heart? So on the bottom of page 102, alright, it says blood flow to the upper and lower extremity is governed by how does blood even get out of the heart. It depends on how much the heart is contracting. If your left ventricle is barely contracting, guess what? Little blood will get out of the heart. If it's contracting where it's supposed to, a lot of blood will get out. Intraluminal blood pressure. An increase in blood pressure means an increase in blood flow out of the heart. And then your peripheral resistance. If you have a high resistance, what happens to blood flow? It decreases. Very good. Okay? If you have a high resistance, that means that you're getting a smaller amount of blood flow. Okay? Think of the E and I. E is what? High resistance. I is low resistance, right? You need more blood going to your brain and your face, correct? So that's why E is high resistance, because it has little blood going to the face. I is low, a lot more blood going to the face. So an increase in resistance is definitely going to govern the amount of blood flow that can get to an extremity. All right, arteries have what's called a higher pressure within them. And you may just want to write this to the side because I did. And I know we've talked about this before, things like, but arteries are high pressure systems. And veins are low pressure, so the complete opposite. Arteries, high pressure. Veins are low pressure. The difference in these pressures is called a pressure gradient. okay? So the difference between the arteries and the veins is called a pressure gradient. 102. And we're just writing all this in. The difference between the pressures of the arterial and the venous is called a pressure gradient. Arteries should be high, veins should be low. The higher the pressure gradient, the more perfusion from arteries to veins. Okay? So the higher the pressure gradient, the higher the difference in pressure from arteries to veins, the more blood flow that can cross over into the venous system. So the higher the pressure gradient, or the higher the difference, the more perfusion of blood from arteries to veins. The higher, so you want your arteries to be extremely high and your veins to be extremely low. That way there's perfusion from one side to the next. There are cases where venous pressure increases. We're going to talk about that in a moment. If the vein pressure increases, even if it's still lower than arteries, you're getting smaller amounts of perfusion. If arteries and veins are equal, you're not getting no perfusion. Okay? So arteries have to be higher than veins in order for the perfusion to go from one side to the next. So think about it. If your vein pressure is equal to or higher than your arteries, that means no blood flow is crossing into the venous system. So what's happening now? No blood's getting back to where the heart. Well, you're going to die. I mean, you're going to die. Okay? So it's very important for that pressure gradient to stay, even if arteries are slightly higher. It's still important. All right, so the third little arrow says during exercise, resistance decreases and vasodilation occurs. All right? So when you exercise, and all of us have had this happen, our muscles start cramping, especially when you first start exercising because your body's not used to all that. Your body can't get all the blood flow needed to the exercising muscle. But over time, that cramping stops, right? Okay? So when you exercise, your vessels dilate to allow blood flow to go to that exercising muscle. And exercising don't mean running, you just walk. You know, when we walk from here to the door, we need our vessels to dilate to provide the blood flow to those muscles. All right, so exercise causes vasodilation because you need more blood flow to the exercising muscle. And so if you have dilation, then your resistance decreases, allowing blood flow to get to those exercising muscles, okay? You don't want the resistance to increase. That's what it says. This allows more blood volume to enter the muscle to support the activity related to exercise, more red blood cells and oxygen, the more metabolic waste. And don't worry about that part, but just know that when you exercise, your vessels have to dilate, resistance will go down to provide for the extra activity. It says the increase in flow during exercise can be as much as 10 times higher than resting. So we need a lot of blood flow when we're walking, okay? We need our resistance to definitely go down. The top of 103, peripheral resistance in capillary beds may decrease in response to heat, inflammation, and infection. All right, so if your resistance decreases, blood volume increases, okay? So you don't have to just be walking. Like I said, if you're hot, why do you think your vessels dilate if you're hot? That's exactly why. It lets the heat out, okay? So when you're hot, when heat, your vessels dilate, let the heat out of your body. If you have an inflammation or infection, vessels dilate to provide blood flow to that infection to treat it, to make it, all right? Treat it faster. So you don't just have to be exercising. Other things can cause you to dilate. All right, more blood entering the limb means the more blood that has to get back to the heart. Exactly. And we'll mention that in a minute. All right, so the opposite happens when you're cold or stressed out, all right, or you smoke. It causes constriction. Why do we constrict when we're cold? To keep the heat in, okay? And so if the blood flow is decreasing, what's increasing? Resistance is increasing. Resistance increases, blood flow decreases. They're inversely. Sorry, you're just, every time I look up, you're just right in my view here.
That's all right.
I'm trying to use these glasses, so I'm like dizzy anyways, but anyhow, all right, it says a pressure gradient exists across all capillary beds with high pressure on the arterial side, low pressure on the venous side. This phenomenon allows perfusion from one side to the next, like we just mentioned. If venous pressure in the veins is equal to or higher than arterial, what that word come from? We are in trouble as little to no perfusion can cross. Okay? That's what I just mentioned a minute ago. Alright, so do we understand arteries need to be higher, veins need to be lower, it's so that blood can go from one side to the next. When veins get equal to or higher, forget it.
So perfusion is just it going from
One to the other.
Okay.
Yep, emptying from arterial to venous side. Yes, ma'am. Alright, hydrostatic pressure is something that we have fighting against us. It's another word for gravity. Alright? So just use your thinking skills for a minute. Do I have more hydrostatic pressure when I'm standing up or lying down? Exactly. So when you're standing up, your body's working harder because of the gravity to get blood back to the heart. Alright? It says in the lower extremities, once blood passes into the venous side, it has got a battle because it's got to go uphill. A significant impediment for blood getting back to the heart is hydrostatic pressure. This is gravity pulling the blood back down towards your feet. Alright? The amount of hydrostatic pressure is related to the person's height and their position. When standing, a taller individual will have a higher hydrostatic pressure than a shorter person. So, the taller we are, the more hydrostatic pressure we have. Alright? If you're lying down, your hydrostatic pressure is 0. And I gave you a handout right here about hydrostatic pressure, which some people didn't get. It's a good little thing to look at. They come from your physics book. Y'all just don't talk about these chapters in physics, so I try to pull out some stuff for y'all. But hydrostatic pressure will be higher in a taller individual, and it'll also be higher if you're standing versus if you're lying. Even sitting up. If I'm standing or sitting, my hydrostatic pressure is lower when I'm sitting. Okay, so it just depends on your position. Alright, the last thing on that page, venous interluminal pressure in the legs is affected by your body position and activity. Individuals who stand for a significant amount a day are more susceptible to the effects of hydrostatic pressure. So there are problems that come along with hydrostatic pressure. Okay? It can. Think about if, okay, I'll give you a little hint. In order for blood to move out of the calf, to be squeezed up your leg to get back to the heart, you have to be moving. That's why it's important not to stand still for very long. So if I just stood here still and did not move, what do you think might happen to me? I'm going to pass out, exactly. Because if my blood is sitting in my calf and it cannot get up my leg to get back to my heart, I'm going to pass out. Once I've passed out, I'm laying down, so what happens to my hydrostatic pressure? It goes to 0, blood gets back to my heart, I wake back up. Okay? So, it mentions in this book about soldiers who stand at attention for a long amount of time will eventually face plant, and that's why. Because your blood, in order to get blood out of your calf, you have to be moving. Okay?
So that's why, like, if you travel, like if you're driving for a long time,
You
your
have to
feet
get
swell
up.
up and legs
Yep.
swell up.
And it'll tell you, like, if you sit at work a lot, or if you stand still, if you're on a plane, whatever, you're supposed to get up and move around because the blood is just sitting there. Now, your hydrostatic pressure is lower when you're sitting, so some blood is getting back to your heart, but you have a chance of getting a blood clot because blood is just sitting there. You got to get up, get it moving around. All right? So, I know, right? He's using his calf muscles right now. All right, on the top of 104. On the top of 104, it says venous pressure is approximately 10 when you're lying, and then 60 when you're standing. So that tells the difference in just the pressure, okay? So,
18 or 80?
Does it say 80? 80, I can't read. 80.
I didn't know you changed
No,
it.
it's 80. The increase in the pressure in the veins leads to vessel distension and pulling of the blood. When you walk, this reduces the pressure. So if standing increases my pressure, all right, we just said that veins need a lower pressure, right? So if it increases my pressure, that tells you right there that standing for a long period of time is a bad idea. Because what's it going to do? It's going to get little to no perfusion to the venous side, and you're going to pass out. So that kind of sums up hydrostatic pressure, okay? It's important that we move around so blood can get back to our heart, so we don't fall out. The big paragraph on 104, venous pulling reduces. So blood is just sitting in your leg. That's going to reduce the amount of blood back to your heart, which results in a decrease in cardiac output. If you don't have a sizable amount of blood getting back to the heart, then you don't have enough getting out. This decrease in cardiac output may lead to hypotension, which is low blood pressure. This is why soldiers standing for attention a long period of time will eventually face plant, like I just said. Once they're lying prone, the hydrostatic pressure is decreased, blood returns back to their heart, and they will wake back up. Okay? A little diagram about hydrostatic pressure. All right, if we're standing still, or hydrostatic pressure is increasing, that means blood is just sitting in our calf. It increases the pressure within the vein, which is called transmural pressure. That's pressure within the vein. Think about blowing up a balloon. When you blow your air into the balloon, what does happen? It gets bigger. That's transmural pressure. Our air is that, okay? So the blood sits in these veins, and the veins get bigger. As the vein gets bigger, the pressure increases. And what happens when venous pressure increases? Perfusion starts decreasing, okay? And that's what it says. So if the pressure increases, perfusion decreases. Veins will distend, and blood just sits there. You have a decreased venous return to your heart, which means you have a decreased output, which leads to hypotension, which is decreased blood pressure. All right? So if we just stand still, veins distend, the pressure inside them gets bigger. Pressure goes up in veins, perfusion goes down. All right? And then the veins, the blood just sits there, causes the veins to get bigger, decreased return to the heart, decreased output to the heart, which means decreased blood pressure. So we all have that. Yeah. Okay. Now, the next thing says because arterial pressure is transmitted through the capillary bed, blood does flow upward to the heart when one is standing. Okay, blood can get to your heart when you're standing. You know, I'm moving around, so something's working in my body to get blood out of my calf. All right? And that's what it says there. If only there was some way to pump blood back to the heart when you're standing. And that's what we're going to get to in just a moment, because these flip-flops are in this book so much. So go on to page 106 and say, hey, go back to what you were talking about. Because we're going to talk about, well, how does blood get back to your heart when you're standing? The top of 106 says venous return. You have 3 pumps that work in your leg. You have the foot pump, the thigh pump, and the calf venomotor pump. That's the one I want you to remember. The most important one is the calf venomotor pump. All right, so the thigh and the foot pump, those are more commonly used in people that are paralyzed. Why? Because you'll have like physical therapy come in and mess with their foot, especially if you're bedbound. You know, you get those little hoses put on your leg, they blow up. They're acting as a thigh pump. They're getting blood out of the calf and up. Okay, but the calf venomotor pump is the most important. It's the primary one that's used, so that's the one that we're going to talk about. All right, so once blood gets from the arterial system to the venous system, it actually just sits in your calf. All right? In order for blood to get out of your calf and get back to your heart, your calf has to, contract. Okay? So venous blood is propelled towards the heart by the calf venomotor pump. There are numerous veins in the calf. We've learned about them: the posterior, the perineal, the anterior, the gastrocs, the soleils, right? Each of these have valves in them. When the skeletal muscles are contracted, the following of them will occur. Does everyone understand what a valve is before I go on? They will open to let blood in, and they will close to prevent blood from going back down. Just like the greater saphenous in the deep system, superficial in the deep system, you have perforators that open up to allow blood into the deep system, but they close so blood cannot get back into the superficial system.
Like a pulmonary valve.
Yeah, same thing. They open and they close, just like in your heart. All right, so you have numerous ones. So when you're during muscle contraction, when the calf pump starts reacting, this is what happens. It says blood volume in the deep veins is squeezed up and out of the calf. The proximal valve will open, allowing blood up. Proximal means what? Closest to the heart. So they're going to open up, but the distal valve will close so that blood cannot come back down. The perforating valves will close so blood cannot go back into the superficial system. Right, so when you contract your muscle, blood comes out of the calf, proximal valves open, allowing blood to go up, distal valves close so it can't come back down, perforating valves close so it can't go back into the superficial system. That's what happens when you contract. When you relax, the opposite happens. All right? So during muscle relaxation, the proximal valves close. It says the distal valves, the bottom on number 6, the distal valves and the perforating valves open, and it allows blood to fill back into the calf. Okay? So when you relax, those proximal valves close, the distal valves open, so whatever blood didn't go up all the way simply comes back down. Then the perforator valves open back up, and this allows blood to fill back into the calf, so that when you walk, the same thing happens again. So do we have that? When you contract, proximal valves open, blood goes up, distal valves close, so blood can't go back down. Perforating valves close, so blood cannot get into the superficial system. Because when we're contracting, we're trying to get as much blood as we can back to the heart, right? But then when we relax again, the opposite happens. Proximal valves close, distal valves open, allowing whatever blood didn't make it to go back down your leg. And then the perforating vein or valves open so that blood can get drained from the superficial system to the deep system. This fills the calf back up, and then when we walk, everything again will happen again, okay? That's how we work. All right, stop me if you don't get there. Oh, we're almost done. I'm so happy. Do we understand capnomotor pump? The valves that open, the valves that close, why they open, why they close, what hydrostatic pressure is, what the effects of it are. Okay, good. Then we're going to go into page 107, what happens when these valves don't work. All right, so if during muscle contraction, my proximal valves open, so blood's going up, but my distal valves don't close. That means all the blood that has worked its way up simply comes right back down. Okay? That is called venous insufficiency. You can have venous insufficiency in your deep system. You can also have it in your superficial system. So remember those perforating veins that go from superficial to deep? They have valves in them. If those valves don't close, all the blood that went to the deep system simply flows right back into the superficial system. So you can have venous insufficiency in both systems, and they both mean different things, okay? Now, venous insufficiency, the most common cause of it, you'll write this to the side, is valve damage. That means those valves don't close right, so blood simply can come back down. So valve damage is the most common reason for venous insufficiency. But another one could be that you have a chronic DVT that has obstructed an outflow vein. Right? So a chronic DVT that has obstructed an outflow vein. It's a chronic DVT that has obstructed one of the outflow veins. For instance, what would happen if the popliteal vein was completely blocked and your body, maybe it had a few collaterals, but let's say it had a few and they were working somewhat, all right? How is blood going to go if you have an obstruction from the calf to the distal SFV if the popliteal vein is obstructed? It's not. It's going to simply flow right back down the leg. And that will have the same effect as a patient that has valve damage, okay? So valve damage or a chronic DVT that's completely obstructing a vein or a reason where blood that comes up simply comes right back down, all right? Venous insufficiency causes swelling. Think about it. If all that, especially let's think about the popliteal obstruction. If blood cannot pass my popliteal vein, or only a little bit can because of collaterals, and all the blood simply goes back down, what's going to happen to my calf? It's going to swell because of the increased pressure and the increased blood flow. All right? If my common femoral vein is obstructed, that means my whole leg's going to be swollen. All right? And the same thing with valves. If your valves don't work correctly and blood can just flow back down, it's going to cause swelling in whatever part of the leg is affected. Okay, so the efficiency of the calf venomotor pump depends on the ability of your muscles to contract. If you're paralyzed, these are not going to come into effect, okay? So we have to manually squeeze those legs or whatever. The competency of the valves. If the valves don't work correctly, what happens? Flows right back down. And the patency of the outflow veins is what we just mentioned. If the outflow veins, the deep veins is another way to remove that. If the deep veins are obstructed, well, it can't pass, so it's just going to simply come back down your leg, okay? So those are some reasons to why insufficiency can occur. It says if there is no muscle contraction, there is no pump action. The resulting stagnation of blood increases the risk for DVT because the blood is just sitting there. Symptomatic venous insufficiency is a chronic condition and usually takes years to develop. All right, so you're going to, like I said, you're going to have this going on for a long period of time before you even start noticing symptoms related to it, before your legs start swelling, before you start. If you don't take care of insufficiency, after time that blood that's sitting there will eat away at your skin and cause an ulcer. So that's another reason. So there can be some side effects, but they take years to develop. All right, there's two different types of insufficiency. You have primary and secondary. So primary venous insufficiency means that you have an absence or a defect in your valve. So that would be the one that's related to valve damage, primary, okay? Secondary could be if your valves have become damaged, but it's because of a DVT, okay? The word post-phlebitic, that just means you're prone to getting DVTs. So secondary venous insufficiency, yes, the valves have become damaged, but why? Because of the chronic DVT, right? Because if it can't pass, it's going to simply flow back down over time. That's going to mess up your valve. So both of these are venous insufficiency. Just one is primary is dependently your valve. Secondary is a DVT that has caused the valve damage. Got that? All right, good. When valves are not working, blood volume that is squeezed upward during contraction simply flows right back down when you relax. All right? If that distal valve doesn't close, what's going to happen? Blood's going to come right back down. And then on page 108, the second arrow, perforating veins, which again is superficial disease, they may dilate when the valves become incompetent. All right, so what you normally not going to see perforators, right? But if you have reflux in the superficial system, it's dilating those perforating veins, so you're going to see them then. Okay. When perforating veins become incompetent, pressure increases in the superficial system. This is where varicose veins come from. So spider veins come from the dermal system. Okay. Varicose veins come from reflux in the superficial system. Venous insufficiency can be either a single system, so it can just involve the deep or the superficial or the perforating, or it can involve two, or it can involve all of them. If you've really bad reflux and got in all three systems, bless you, okay? So it's very important that we look at all three ways to check and see what system it is. And that's what I've got to explain to you. Okay, I got a little bit more time. Before I explain that to you, yeah, let me explain that to you. All right. Turn back to page 107 for a moment. All right. The page, turn your book upside down because I don't like the way that, or you can just use your imagination. But veins are supposed to be below the baseline, okay? This book has veins above the baseline. That's why I said turn your book upside down. All right, if you want to check for reflux in the deep system, in any system, there's a couple things you have to do. The first one is called augmentation. And I can't even say the word. Augmentation. There we go. A-U-G-M-E-N-T-A-I-T-O-N. Augmentation. That's the first thing, and I'm going to tell you what that means. Augmentation is your first step. This is to check for reflux. Okay? So if they come in, their legs are swollen, they're brown, they've got ulcers, they've got varicose veins. We got to find out if they have reflux, but we got to figure out what system it's in first to know what kind of treatment can be done. All right, so to test them, the first thing is to do augmentation. And what you'll do is you'll lengthen your vein out in your Doppler, just like you've been Doppler arteries. Okay, blood should be below the baseline. Augmentation means you'll squeeze below your probe. So if my probe is here, I'm going to squeeze here. When I squeeze, that kind of acts like a pump and pushes blood up the leg. All right? So once I push and squeeze blood up the leg, you should see blood actually go on the opposite side of the baseline and wrap around it. And there should be a picture, because they do augment right here. So let me show you that. All right, so augmentation means you will compress distal to your probe. You're acting as a pump, squeezing blood out of the distal part up the leg. Okay? Oh, where is a good augmentation picture? Oh, here's a beautiful augmentation picture. All right. So, venous blood flow before. She squeezed the calf, pushing blood up to the proximal valve. Okay? So that's what this is. It wraps around the baseline. Then, once the distal valve should close, venous flow continues again. Okay? So if you are able, when you augment it, if you're able to show this right here, that means that their proximal valves are opening correctly. So augmentation tested. It's testing to make sure that your proximal valves open and your distal valves close. That's what augmentation is doing. Okay? So again, common femoral vein. That means that her probe's here, so she's squeezing here, pushing blood up the leg, and that's what you're showing there. You're showing as it wraps around the baseline. That means that the proximal valves are opening up, allowing blood to come up the leg, and the distal valves should close. Then once the distal valves close, venous flow returns again to normal. Okay? So augmentation, squeeze below the probe. Proximal valve should open, distal valve should close. Alright? The second one is called the Valsalva maneuver. V-A-L-S-A-L-V-A. Valsalva maneuver. And they don't have a Valsalva maneuver on here. This is what's in your book. Alright, Valsalva maneuver, it makes sure that the proximal valve closes. Alright? Because what's going to happen when you relax? your proximal valve should close, right? All right, so augmentation will test the distals to make sure they close. Valsalva will test the proximals to make sure they close. And the Valsalva maneuver is pretty easy. Again, you get your venous waveform below the baseline. Then you have the patient to bear down, okay? Once you bear down, blood should stop. Should stop completely until the patient relaxes again. This book shows reflux, okay? If, when you bear down, the flow stops, that means that their proximal valves are closing, allowing no blood to get back down the leg. Okay? That's a good sign. That's what you want. You want blood to stop. Then when they breathe again, it'll resume again. This book shows reflux. So, again, their venous flow is on top of the baseline. Once the patient bared down, flow went on the opposite side of the baseline. That's called reflux. Okay? So, here we go. This is kind of backwards too. I hate this. But here you got your venous flow. I've done a Valsalva maneuver. Now my flow has inverted and went on top of the baseline. That's a positive sign of reflux. Okay? But that is involving their proximal valve. So when a patient has reflux, you have to test which valves are being affected. Is it the proximal valve? Is it the distal valve? Augmentation will test and make sure that the proximal valve's open, because when you squeeze, you're pushing blood up the leg. When you relax, the distal valve will open back up and allow blood to continue again. Now, Valsalva is the opposite. When you bear down, you're pushing blood back down your body, okay, when you bear down. So you want your proximal valves closed so no blood can get past that level. So that's why no flow will be seen in a normal Valsalva maneuver. If when I bear down, you see flow, it's on the opposite side of the baseline, that's called reflux. That means that my proximal valves are not working, allowing blood to go back down my leg. No, we're testing for reflux. By doing the Valsalva and the augmentation. That's what we're testing for. We're just testing which valves have reflux in them. Is it a proximal or is it the distal? Okay. Alright. And then go to page 108. And it goes over chronic outflow obstruction, which we said is another reason for venous insufficiency, right? Alright. Venous insufficiency can also result from chronic outflow obstruction. It's most commonly going to be in the iliofemoral, so in the iliac or the common femorals. Because of its DVT, venous outflow is restricted by partially, or it can have small collaterals around it. This will increase venous pressure because all the blood flow cannot get out of the system, so it simply comes back down, which will result in limb swelling, discomfort, and claudication. Claudication is pain when you walk, okay? Because we just said when you exercise, you need blood, you need more blood flow, so anyhow. Symptoms of venous insufficiency is recurrent swelling because of the increase in the venous pressure, because all the blood that's supposed to go out of the leg simply come back down, increase that venous pressure, which increases what? Hydrostatic pressure, okay? Chronic limb swelling can occur also. You can have spider veins, varicose veins, and reticular veins. All those can also occur. Now those three are because of reflux in the superficial system. So spider veins, reticular and varicose veins are all because you have reflux in the superficial system. And what I left off a minute ago because I got distracted. When you're testing for reflux, you have to do the deep system first. You got to look at the common femoral vein, the superficial femoral vein, the pop vein. Those are the three most common veins. So your augmentation and Valsalva at all three levels. Then you move on to the superficial system. So you do the greater saphenous vein and lesser saphenous vein. Okay, same thing, augmentation and Valsalva. And then you can determine which system is causing the reflux by the findings that you will have whether, flow goes on top of the baseline. When you do down balance, that's reflux. You can't augment if you squeeze and nothing happens. All right, that's letting you know the proximal valves are not opening correctly. So, depending on your findings, let you know where the reflux is. The last thing is on page, almost last thing, is on page 109. It says venous claudication is a burning sensation or pain in your legs when you exercise due to the outflow obstruction and the blood just sitting there. Stasis dermatitis is when your legs turn brown. Have you ever seen someone look like they have a pair of socks on, but they don't? All right, that's because of reflux. And then you can also get ulcers, venous stasis ulcers. So if the blood is just sitting somewhere, it will begin to eat away at your skin. Okay. If you ever have an ulcer, if it's medial on your body, it's a venous ulcer. If it's lateral, it's an arterial ulcer. So you can tell by just by looking at an ulcer on a patient what's going on. Do they have a venous issue or do they have an arterial issue? So venous ulcers are medial, arterial are lateral. Alright, I promise this is it on page 104. I know, right? I told you it was a lot once we got to the hemodynamics part. 104. Alright, just like with arteries, you have normal flow, it's supposed to be triphasic, okay? Veins have two normal types of signals. They have what's called spontaneity, and it's not in here. Spontaneity and respiratory spasticity. Spontaneity and respiratory spasticity, which is a PH, not a F. Spasticity, P-H-A-S-I-C-I-T-Y. Those are your normal venous signals. Spontaneity and respiratory spasticity. What spontaneity means is as soon as I put turn my pulse Doppler on, I should be picking up flow. It's spontaneous. I don't have to do any work to make my venous signal come in. Okay? So spontaneity means it comes in as soon as I put my probe down, pretty much. And then respiratory spasticity means exactly what it says. It changes with my breathing. So venous flow, unlike arterial flow, will change depending on if you're breathing in or breathing out. Okay, so spontaneity, flow that just comes in as soon as I put my probe down. Respiratory spasticity will change when I breathe. So that's where we're at on respiratory variation on page 105. If venous flow changes when you breathe, so it changes when you inspire and you expire, okay? It says venous blood flow in the extremities is affected by respiration. When one inspires, the diaphragm will move down and it will increase your intra-abdominal pressure. That's the first step. When you breathe in, diaphragm moves down, which increases the pressure in the abdomen, okay? Because of this increase in the abdomen, the IVC will become compressed, and blood flow out of the lower extremities is temporarily stopped. All right? So when you inspire, your diaphragm moves down. It increases the abdominal pressure. This abdominal pressure collapses the IVC, and blood in the legs stops temporarily. Okay? So inspire, blood stops in the leg. Alright, now the next thing is when you exhale, the opposite happens. The intra-abdominal pressure is reduced because the diaphragm moves back up. The IVC opens, so flow in the legs will resume again. Okay? So it's just the opposite of that. And it says in the very bottom, so in a nutshell, when you breathe in, flow in the leg stops or slows down, and when you breathe out, it resumes again. The last thing you have to know is the opposite of the arms. The arms are completely opposite. Okay, so if when we breathe in, what happens to the flow in our legs? It stops. So if arms are opposite, what happens to them? When you breathe in, flow in the arms will increase. Exactly. It's the only opposite. And then when you breathe out, flow in the legs increases. So what does flow in the arms do? It decreases. I don't know. I know it does. And also, with inspiration, because your IVC is compressed, flow to the heart decreases. Okay.
What's our homework for?
The 5 I gave you. And then read ahead chapter 6.
Guys, can anybody see my phone, the white cell phone?
No, you need us to call you?
I tried. Yeah, I checked it out. I'm going back in there.
Yeah.
He said the inspiration was in the heart.
Because of the IVC. Yeah, I don't remember seeing any